Welcome to this Rajilman. This is Public Health Global Grant Series. Echoing the success of public health in Sri Lanka, the Department of Community and Family Medicine, Ministry of Jaffna, with this grant, the Rajilman, this is Public Health Global Grant, to echoing the success stories of public health in Sri Lanka. This year, 2026, the Sri Lanka is celebrating the 100th year of public health stories, public health institutions. So, the stories, several stories we have and several achievements we have in public health, that's example for other countries. These stories to be documented and to be transmitted to or transferred to the next generations, those who are working in public health and other sectors, that will make their attitudes and practices changes. So that will make forward Sri Lanka and the globe for prevention of other diseases. Thank you. Now, today we are going to do this podcasting with a renowned professor who is working hardly for eliminating diseases and public health programs, Professor Rajitha Wikramasinghe. He is Cadre Chair Professor of Public Health at University of Kelaniya. He contributed several ways for the success in Sri Lanka to eliminate diseases, to control programs. We are welcoming Professor Rajitha Wikramasinghe.
Thank you very much, sir.
Welcome, sir. So, yeah. Sri Lanka, the malaria story. Today we are mainly focusing on you with the malaria control program and the success stories of malaria. So if you see the trend in 1930s, it was a huge burden and the mortality due to malaria. Later we were able to control it, and in 2012 we got that no more indigenous transmission of this malaria. So, sir, in your experience in epidemiology and also public health, what do you consider the most critical lessons for sustaining malaria-free status in the country?
Okay, Dinesh, thank you. First of all, I'd like to thank the organizers for inviting me, especially the Department of Community and Family Medicine of the University of Jaffna. It's a pleasure being with you. And also, as much as you said that malaria is a success story in Sri Lanka, there is also a failure that needs to be documented and it's a lesson for everyone. And that is where we achieved near elimination in 1963, where we reported only 17 cases, of which only 7 were indigenous, and then there was a massive outbreak following in 67, 69, that period, with over 500,000 cases. Malaria in Sri Lanka has generally been riverine, right? It has been prevalent in the dry zone of the country, and very often it has been there in epidemic proportions in the intermediate and wet zones, especially when the southwest monsoon rains fail. So traditionally, malaria has been prevalent in the dry zone of the country, and it has also been claimed that it was one reason for the depopulation of the dry zone. This has been actually recorded by Robert Knox.
Only the dry zone areas.
Yeah. So there has been a big problem there. So with the failure of the southwest monsoons, there used to be pooling of rivers and then all the breeding sites were created. Then in 1992, there was a big ministerial conference where they sort of changed the strategies for malaria control and all. And that's where early diagnosis and treatment, as well as focused vector control, were recommended.
This conference held in
1992, I think in the Netherlands.
Netherlands. Okay.
And then, so we were also signatory there, and then we also changed our strategy.
Yes.
And then in the late 1990s, we came up with the Rollback Malaria Initiative. So that was a renewed impetus.
Rollback Malaria Initiative. So can you explain more about that, sir?
Yeah, so Rollback Malaria RBMI, Rollback Malaria Initiative, was pioneered by the former Director General of WHO, Johan Brundtland. So that was in the late 1990s. And she did it because when she was campaigning for the election, most of the African countries said malaria is their biggest problem. So then the RPMI was initiated, and then in the early 2000s we came up with the birth of the Global Fund.
Global Fund. Initially it was GFATM, then Global Fund, I think so.
Yeah, so GFATM is for AIDS, tuberculosis,
and malaria.
So
Yes.
still they are functioning.
Function.
In addition, in the 1990s, there were three very important developments that helped to control malaria. That was RDTs, one. So
Okay.
that
was
is just at the point of care.
Okay. Earlier we had only the microscopy and
Yeah.
take the blood and yeah.
So this is much quicker, and you didn't need expertise to read the slide.
Right. These are ground level. This primary care staffs can do that. Yeah.
Then came the LLINs, insecticide impregnated.
Yeah.
So that is
And the things. Yeah.
And then the other important one was the artemisinin combination therapy.
Therapies. Yes.
So that changed the entire game plan.
Game plan. Yes. Plasmodium falciparum is crucial.
So those three developments were very significant for control. And in Sri Lanka, if you take that from about 2000 onwards, 1999, 2000, we had more than 200,000 cases.
Cases. Yes.
And then it slowly started dropping.
Dropping.
This was even though there was a war going on in the
Ongoing war with the country. Yes.
And by 2004, we had achieved the threshold to eliminate malaria. That is one case per 1,000
Population. So we achieved that threshold in 2004.
Yeah, but we couldn't proceed because of the war. So we started the elimination then in 20.
So if you know to have a war, I think in 2006 or 7 we should be able to.
So those were some of the
things.
and then during this period, in the late 1990s, we were starting to conduct what are called mobile malaria clinics. Yeah, they focused on traditionally malarious areas. And then they used to go and then
screen
people and treat. So that reduced the
active surveillance was so intense in that areas. Active surveillance. Usually we depend on passive surveillance, but here active surveillance was so intense.
The primary aim was to reduce the burden,
the undetected cases and
cases that also contributed. So those were some of the in malaria elimination, unlike in other diseases, Malaria elimination is elimination of transmission.
Yeah, not the vector.
No, you
Parasite.
take let's say filariasis or something. It is you bring the MF rate to less than
1
10,000 or what.
That is enough to eliminate the filariasis
Yeah, you eliminate filariasis as a public health problem. Not, you don't eliminate
the organisms. Organisms still there, but the public transmission is eliminated. For malaria,
it's
organisms also zero incident, zero. Yeah,
but the vector is there.
Vector is there, but no more organisms in the country.
Yeah. No more transmission.
No transmissions. Yes.
So I think that's very creditable for a
team. Yeah, I think so. Okay, sir. So, how did the institution community, especially the government leadership, through the anti-malaria campaign, contributed sustaining momentum, I think, to control, eliminate, and post-elimination process in the malaria in the country, I think.
Now, if we go back to the history of malaria control in the country, organized malaria control activities were started in 1911.
Before our public health campaign started, the malaria campaign started.
Yeah, and that was basically it started in Kelaniya, and so that was basically the anti-malaria campaign, which was started in 1911. And it took us more than 100 years to
eliminate. Exactly 100 years then it took.
Yeah. So during this period, we had a very good infrastructure. We had the campaign, we had the resources, and this was continuing a legacy of over 100 years.
And government also committed for that. I think every government who coming to the power.
And if you take, let's say in the 70s, 80s, more than 50% of the public health budget was spent on malaria.
Primary task is malaria, I think, for them.
Yeah, and most of it was for insecticides.
Insecticides. Every house is sprayed with.
So that way it was maintained, and then even after elimination, the ministry did not dismantle the anti-malaria campaign. So that structure is there to give technical guidance.
But what happened in 1960s then, after 1963?
Yeah, 1963 was resources were limited.
Limited. Structure was there, but
the funding was
limited.
Used.
Okay.
And also what then happened was there was a non-immune population.
Okay.
So if there is an outbreak today,
Okay. So
those
both coupled in the infrastructure and there's a non-immune people, both coupled for the resurgence of this malaria.
And then for the elimination drive, I must say global funding was very important. Because there were things that the government could not fund. For example, government did not have a card for, let's say, a surveillance officer or a mining officer.
Yeah.
Or a GIS officer.
GIS officer.
Now the
entomologists and other kind of teams are not.
Yeah, entomologists were there.
Yeah. Okay.
But these special items or these special cadres were made possible by GF funding.
GF funding. Okay.
They were given by the government.
It's a good lesson for us also for current dengue and other things.
Yeah.
Where we are lacking, I think we don't have any other funding for dengue, especially depend on government. Maybe some loopholes, maybe we couldn't find things through that, and we had to focus on that thing. So,
So I think global funding is
very great for that. I think that not only for malaria, also tuberculosis and HIV in low prevalence, their fundings are very things. So okay, so in that case, I think I want to ask you, share your childhood memories. I think your father also pioneer in controlling malaria in the country. Can you share something related to that?
Okay. I also have had malaria, so experienced malaria.
Yeah.
So I learned a lot from my father as well during his informal chats with other people. And so that was also very enlightening. And yes, he was in the malaria program from I think 1956 to 1972.
Oh, longer period, yeah. Around 16 or 17 years. Yeah. So, a very crucial period in the second time wave comes.
So he was also the director of the program during the resurgence.
Okay.
And one important thing during the resurgence was that the prevalence of falciparum, their strategy at that time was to keep it less than 1%.
1%. That's a strategy. Not to eliminate things.
No.
Yeah. So that's the thing. Now, how they initially plan for control malaria, then change into the track into eliminating malaria. So that's the thing. After 1992 only.
Yeah. So
the plan given.
Right. So for elimination, the main thing was to get rid of the reservoir infection. So some things that really contributed were the mobile malaria clinics, then the targeted vector control, and I think those two were the most important aspects.
Yeah.
And also later on introduction of LLINs, but LLIN introduction was in 2004, after which
already started the process. So that's augmented the process, I think, LLIN. Yeah.
And ACTs we started only in 2007.
Artemisinin combined.
Correctly. So before that, it was basically very good public health
practices to control, but these are the things driven us to eliminate malaria. I think this possibility is there.
And also there were collaborations, important collaborations. Again, I must say global funding, and collaboration was with armed forces.
Armed forces, yeah. The other question is that in the multi-sectoral involvement.
Right.
So mainly this GFATM and WHO technical support and financial support, and armed forces are the main people. The other one during the war also.
Now what was happening was, so they were stationed in jungles and they used to the armed forces personnel used to come down with malaria. As soon as they get fever, what happens? They used to go to the medical corps, and then they say fever, they get the treatment and they get leave. They used to go to their villages and
spread all the places.
Start transmission in those areas. So what the AMC did was had a pact with the armed forces. If they had malaria, they were kept in the barracks and then given the full medical cure. So that then confined the spread to.
That's win for the malaria. Also the win for the army or the military people. You keep the forces active. So win-win situation like it, I think so.
So that was, I think, very important. And even during the height of the war, I think the government used to send some insecticides around to the uncleared area.
Cleared area also, they're very keen on that to control there also, I think.
And even during that time, there used to be, they used to stop the hostilities on days of immunization days and all that.
They're also very supportive, I think. Other countries are very supportive for controlling, because they're also suffering with the same problem, I think so.